All right, so let's resume infection. And I'm going to go back to this PowerPoint and we're going to start talking about some of the other things that you need to know as far as testing is concerned. So if a patient has an infection, any type of infection, depending on that infection, there are tests that we can do. And I'm highlighting the tests that you need to know and understand, and I'm going to explain them. So the first one that you need to know is something called a culture and sensitivity, also known as a C&S. So you might hear the physician say, get me a urine culture with a C&S. So what the physician is saying is get a sample of the urine and send it for analysis and do a culture and sensitivity. A culture takes that urine or pus or sputum or whatever it is, puts it in a lab in a petri dish and allows whatever bacteria are in it to grow over the course of 2 to 3 days, okay? And so the culture, I'm going to put notes on this, the culture determines and identifies the type of bacteria. So when the culture has grown after 2 or 3 days, they can look at it and go, oh, it's Clostridium difficile, or oh, it's Pseudomonas, or it's Enterococcus, or it's Staph aureus, or whatever it is. The culture identifies the type of bacteria. The sensitivity identifies what antibiotic to use. So in other words, what antibiotic, come on, Mary, biotic, the bacteria is sensitive to. So let me give you a scenario. You have a patient that is an older woman and she is displaying symptoms of a possible urinary tract infection, okay? And she's complaining to you, oh, you know, all I do is pee, I'm peeing all the time, and when I go, not much comes out and it's burning. Well, that sounds like she's got a UTI. So you're going to call the doctor and you're going to say, hey, you know, this is Mary, I'm the nurse caring for Mrs. Jones in room 128. Her date of birth is, you know, 2/25/43. She is displaying the following symptoms of a urinary tract infection, polyuria, frequent urination, dysuria, which is painful urination. May I get a urine analysis with a culture and sensitivity, a UA with a CNS? And the doctor's going to go, absolutely, thank you. And then the doctor may say, and this is important, what I want you to do is I want you to get the urine analysis with a CNS, and I want to start her on a broad spectrum antibiotic empirically. And I'm actually going to write these notes on this PowerPoint for you guys as well. So let's get rid of this and let's get rid of this. So the doctor orders, say, a UA, which is a urine analysis, with a C and S, culture and sensitivity, okay? And then says, start a broad spectrum antibiotic empirically. So the doctor means, I want you to go get the urine analysis from this patient, and then I want you to start an antibiotic, say amoxicillin or penicillin. Those are broad spectrum antibiotics. We're going to start going into antibiotics in pharm. So there are lots of antibiotics. Antibiotics either stunt the growth of or kill bacteria. Not viruses, not fungi, not anything else. Antibiotics only affect bacteria. So when you think antibiotic, you think antibacteria. That's what antibiotics are. And antibiotics, some of them are broad spectrum and some of them are narrow spectrum. What does that mean? Broad spectrum means that, say, amoxicillin. Anybody that's got a kid has at one point given that kid the pink bubble gum crap, right? Everybody. That's amoxicillin. It covers all types of bacteria. It'll kill all different kinds of bacteria. So we don't know what kind of bacteria is causing this lady's urinary tract infection. We won't know until we get the culture back. But if we wait 3 days to start her on an antibiotic, it's going to get worse. And with old people, a urinary tract infection can really cause big problems, like can cause change in mental status, confusion, those kinds of things. So we're going to get her started on amoxicillin, say. Then when we get the results of the culture and sensitivity back, it's going to say, oh, we identified Escherichia coli, E. coli, as the bacteria, and that happens to be sensitive to ciprofloxacin. So we're going to stop the amoxicillin and get her started on Cipro. But at least we didn't make her wait the 3 days until we got the results. Does that make sense to everybody? So that's what it means to treat empirically. You're treating based on symptoms until you have more specific information. Okay, so that's an example. So make sure you know a culture and sensitivity. Culture means you're checking to identify what bacteria are causing the infection. And the sensitivity part tells you what antibiotic to use. So make sure you know that. That'll be on your test. Next week, we're having a test. Okay? All right. Moving along. Then the next test that I want you to know about is a CBC, also known as a complete blood count. Okay? Now, a CBC contains a lot of things. I'm going to actually add a slide here. Come on now. There we go. To continue the CBC. What is a CBC? Okay. So CBC is a complete blood count. And what it has in it, and it contains the following. It contains red blood cells, white blood cells, possibly with a differential, and I'm going to explain all this in a minute, differential. And then, let's go here, hemoglobin, hematocrit, and platelets. Okay, so we're going to start here. RBCs are red blood cells, and I want you guys to start memorizing values now because you have a lot of labs that you're going to need to know off the top of your head. And so if you do them a little bit at a time, it makes it easier. So start now, okay? So red blood cells, hemoglobin, and I'm going to explain all of this in a minute. Hematocrit, oops. Platelets, also known as thrombocytes, and then white blood cells. Okay, so red blood cells are the baby hemoglobins, all right? Red blood cells, and by the way, all of these, red blood cells, hemoglobin, platelets, and white blood cells, they're made in your bone marrow. Okay, that's where they come from. They come from your bone marrow. In a normal, healthy, average adult human being, red blood cells should be 4 to 6 million. Hemoglobin, that's when the red blood cell picks up iron, heme, and then is able to carry oxygen through your body and feed it to your organs and your tissues. Hemoglobin should be 12 to 18. And for some of these, I'm going to put up a lab value cheat sheet that covers all the labs that you'll ever need to know. For some of these, you'll see there are male values and female values. Don't worry about that, okay? I take, if it's male and female, like hemoglobin, I take the lowest number, the highest number, and lump it together because you can't memorize all of that. Just, you know, hemoglobin is 12 to 18, okay? I'm going to skip hematocrit for a minute and go to platelets. Platelets, which are also known as thrombocytes, are part of what you need to make your blood clot, okay? And platelets for a normal, healthy, average adult should be 150,000 to 450,000. Then white blood cells, and you have 5 different types of white blood cells. The total white blood cell count, should be somewhere between 5,000 and 10,000. When you see that number elevated, that is a sign of infection. Okay, that means that your body's making more white blood cells to fight something off. So normal white blood cell count is 5 to 10,000. A differential is what breaks down the 5 types. My God, Mary, come on. The 5 types of white blood cells. And you don't need to know all of this just yet, okay? The ones that you need to know, I'm going to highlight. You need to know red blood cells are 4 to 6 million. Hemoglobin is 12 to 18. And white blood cells total are 5 to 10,000. Oops. So those 3 lab values you must know. Okay? Matter of fact, stars or something here. And we'll get to the other numbers in the term, but this is a good start. So that's 3 lab values that you need to know. Red blood cells, hemoglobin, and white blood cells. Okay? All right. Moving on. When we talk about how your body can protect you from diseases, this is something else that you need to know. We talk about immunity. And your immunity, I'm actually going to get rid of innate because that's confusing, okay? We're going to call it natural immunity or acquired immunity, okay? And natural immunity means that, I don't even want to have species specific, okay? I'm going to say you have had the disease, and so now you're immune to it. Okay, you've had the disease. So for example, when I was a kid, I had the chicken pox. There was no chicken pox vaccine when I was a child. And also all 3 of my kids had the chicken pox, okay? 2 weeks apart too, those little ball busters. So the oldest one came home with the chicken pox, and then a week and a half, almost 2 weeks later, the second one got him, and then the baby got him last. So it was 6 weeks of aggravation, basically. But once you've had the chicken pox, your body recognizes it, builds up antibodies, and if you ever come in contact with it again, you won't catch it. You're immune to it. Your body will say, oh, I remember that virus. Kill it. Don't let it in. So you have specific antibodies that your body has made to protect you from that disease because you had the disease. Okay, part of what they're doing with COVID-19 is they're trying to figure out how to do immunology testing on so many, millions of people to determine who has the antibodies. Because if you have the antibodies, you had the disease, right? And they believe that now you're immune to it. There's still a lot about COVID that we don't know. But natural immunity means you had the disease, and you naturally developed your own immunity to it, okay? Okay. Now, then the other thing that we want to talk about is what's called acquired immunity, okay? And I'm going to get rid of this. Acquired immunity means that we had to give it to you, okay? And I'm going to have to differentiate this way. Okay. So, Acquired immunity, first off, vaccinations, okay? When all of you came to PRISM, they had a list of things that you had to get done before you could go to clinicals. You had to get a PPD, two-step. You had to get titers for your MMR, measles, mumps, and rubella, right? So why? Because we needed to know that you were immune to measles, mumps, and rubella, and we needed to know whether or not you had tuberculosis, obviously, before we let you into clinical sites. So the titer that you had done, what is that? That's the blood test that checked your blood for the presence of antibodies specifically against measles and mumps and rubella, okay? Which means that you probably had the vaccine as a child or maybe even more recently. And when we give you the vaccine, what we're actually doing is we're giving you a little bit of the virus, okay? It's not activated, but it's a little bit of the virus so that your body goes, ooh, that's a bad guy. And your body makes antibodies to fight it off. That's how vaccines work. And by the way, like the flu shot, people say this to me all the time. I got the flu shot, then I got the flu. Well, number one, it takes 2 weeks for your body to make antibodies. So if you're telling me that you felt sick the next day, you're full of shit, okay? It's not possible. Or if you're telling me that you felt sick the next day, coincidentally, you were exposed already and it already incubated and now you're getting symptomatic. So the flu shot is a dead virus. It cannot give you the flu. The end. It is attenuated. Attenuated means that the virus is not alive. Flu shot is not alive. So, but again, takes about 2 weeks for your body to make the antibodies against the flu. Now, we used to think that when we gave you an immunization for things like pertussis and polio and measles, mumps, and rubella and all that, that you were good for life, right? We used to think that you were good for life. But now we know that there's something called waning immunity. So in other words, that's why you have to have the titers for the MMR done. Because we know now that for some people, and we don't know why, for some people, the immunity wears off. The antibodies just wear off over time. So now, like for example, I had MMR titers done 2016 was the last time. And I was still immune to measles, mumps, and rubella. I haven't had that shot since I was a little kid. And y'all know how old I am, so I'm still immune. Some people, it wears off in 10 years. We know that, for example, diphtheria, tetanus, and pertussis is whooping cough, you have to get that every 10 years because the immunity wears off, right? So the reason that we do titers is to see if you still have active immunity. You still are actively immune. You still have antibodies that will fight off that particular disease. So that's artificially acquired active immunity. We give you a vaccine, right? Artificial, because we're giving it to you. Artificially acquired, and it's active immunity. You're building up your own antibodies, okay? Well, then we have another way to give you immunity, but it's temporary, okay? And I'm going to put this here, passive and temporary. So let's say that you are going overseas. You join the Army, okay? And you're getting shipped off overseas. Well, we don't have 2 weeks to wait for your body to build up antibodies, right? So what we're going to do is we're actually going to inject you with immunoglobulin. In other words, we're going to give you an injection of the antibodies from another human being, ready-made, ready-made. So you're immediately immune to like malaria and any diseases that we don't typically see in this country, but that you might be exposed to when we send you wherever it is we're sending you, okay? So artificially acquired passive immunity means we're giving you antibodies from somebody else, so you're immediately immune, but it's going to wear off. Passive immunity is temporary. The immunity is going to eventually wear off in a month or 2 months, depending on what diseases we've given you antibodies for. Okay? So it's instantaneous. You are immune immediately because we're giving you the ready-made antibodies, but it is only temporary. That is artificially acquired passive. Okay? Everybody with me so far? Y'all with me? Nod. Okay. So that's that. All right. Moving on. Let me delete this. All right. We're not getting into this. I am not getting into Ebola. No one's going to ask you about any of these. I don't even want to talk about the World Health Organization and what's happening right now with the so-called president. Okay. We're going to talk about nosocomial infections. Come on. Oh, whoops. Nosocomial infections. I'll tell you, I can't type today, can I? Okay. So an infection that is contracted in some type of a facility is called a nosocomial infection. You need to know what this means. It's an infection that you get from receiving care in a healthcare, I'm going to call it facility, not agency. Okay? Like a nursing home, a hospital, any of those things, okay? Risk factors. Well, I'm going to change this to the patient's condition, right? Is the patient old? Are they immunocompromised? That would make them a higher risk. Are they receiving multiple antibiotics? Because antibiotics kill good stuff and bad stuff. Or are they on a high-risk unit? Are they somewhere where there are a lot of really sick people around them, and now they're more at risk, okay? The most common pathogens that you see in healthcare facilities, and I'm actually going to change this. Oops. Okay. We are not going to get into E. coli just yet, but we are going to talk about Staph aureus, and we're going to talk about vancomycin resistant, enterococcus. I'm going to make this methicillin. Resistant. Okay. These two infections here, methicillin-resistant Staphylococcus aureus and vancomycin-resistant enterococcus. Okay, and I'm going to highlight this whole page. These are the two most common nosocomial infections. In other words, when you're in a hospital, a nursing home, any type of a healthcare facility, if you're going to get a nosocomial infection, I'm going to bet the farm it's one of those, okay? And let me explain what they are. And I'm going to also put something here called MDRO, which stands for multi-drug resistant organism, okay? So if you get a nosocomial infection, it's usually a multi-drug resistant organism. And so that means that it's a bacteria, because the bacteria is a living thing. It's got a cell membrane and a nucleus. It's alive. Bacteria are alive. And bacteria, by the way, can live on inanimate objects. They can live indefinitely. They're not like viruses, where viruses are self-limiting and they need a host. Bacteria are living creatures. They're microscopic, but they're alive. So they live and they can change. They can mutate over time. Let me explain. When you hear MRSA, what does your brain think? Do you go, ah, MRSA? Anybody, hear, like, think something bad when you hear it? So MRSA is just a type of bacteria. Staphylococcus aureus is the bacteria, but over time and for lots of reasons, it was able to mutate itself and become resistant to even the strongest antibiotic that we have, which, by the way, is vancomycin. Vancomycin is the queen mother of antibiotics, okay? But MRSA, that particular strain of Staph aureus bacteria, has become resistant to it. So we are at an impasse as far as how to treat it. So if somebody gets MRSA, which, by the way, you can get MRSA in your respiratory tract. You can get MRSA in a wound, okay? MRSA is just the name of a particular type of Staph aureus bacteria that has mutated and become resistant to many medications. Vancomycin is the only thing that's going to work to kill it, okay? The next one is vancomycin resistant Enterococcus. Enterococcus is the name of the bacteria, and that has mutated and now has become resistant to vanco. Is that not a little scary? Because I just told you, vanco is the strongest antibiotic that we have, but the vancomycin resistant Enterococcus doesn't respond to vancomycin. Usually with VRE, we have to treat the patient with multiple antibiotics to try to kill that. VRE is typically in a patient's urine. It's in a patient's urine. I'm going to put that on this slide also. Okay. Urine. Methicillin-resistant Staph aureus, it can be anywhere. It can be wound or respiratory. Let's do this. Let's make another slide. Oops. Don't want to do that. That's what I want to do. All right. And I am going to copy all this. There we go. MDROs. All right. So make sure you understand what a nosocomial infection is. That's something that you get in a facility. And make sure you know that the two that are most common are MRSA, methicillin-resistant Staph aureus, and vancomycin-resistant Enterococcus. How does this happen? I just want to give you a brief explanation of why they become resistant. So this way you'll know. For years and years and years, many people, they would get a cold and they'd go to the doctor and be like, I have a fever, I have a cold, I have a cough, I want an antibiotic. Well, the cold is a virus. Antibiotic won't work. But oftentimes doctors will like, shut that biatch up and give her an antibiotic. So antibiotics were overused, number one. Number two, misuse of antibiotics. Patient goes in for a respiratory infection and it's viral, but they still get an antibiotic, but they don't even finish it. So they'll start taking it and then 3 days into it, they'll go, I'm feeling better. I don't need to finish this. They don't finish it. Any bacteria that they had inside them has now been exposed to just a little bit of the antibiotic, just enough for the bacteria to go, now I know what you are, and mutate and be resistant to that antibiotic. Okay, so the overuse and the misuse of antibiotics, we as humans created MRSA and VRE. Also utilization of antibiotics in like cows, dairy farming, right? You know, if you notice young girls nowadays, 10, 11, 12 years old, They got them some body sometimes on them, right? They look older than what they are. A lot of that has to do with growth hormone and all the antibiotics and chemicals that we're feeding our dairy and our, our sources of beef and etc. That's causing this, what we call precipitous pubescence. In other words, they're starting to mature way too fast for their age. Okay, so we're doing a lot of damage as human beings, and then we wonder why things like COVID happen. We're like, how could that happen? Well, guess what? You shouldn't be eating bats. Bats are not on the menu. Okay, if you're eating bats, somebody got to have a conversation with you and talk to you about what's edible. Okay, so that's how we did this. Furthermore, here's one more thing. You will not see adult human beings drinking milk the way we do in this country anywhere else in the world. Okay, milk is for children and babies. Like, adults typically don't drink milk, but because there's such a high demand for milk in this country, we have these big, huge dairy farms, and they're pumping those cows full of growth hormones and antibiotics and everything else. So we don't even know, what we are ingesting in a lot of the things that we eat. So, all these things are contributory factors to why these organisms over time have become resistant and harder to kill. Anyway, all right, so that's that. Next, we are going to talk about, we're almost done infection. You're probably like, Jesus, you sure? Hand hygiene before and after patient contact and glove use. We already talked about that. Make sure you know proper hand hygiene, okay? You wet your hands with clean running water, put on the soap, lather for 20 seconds, sing happy birthday, sing row, row your boat. I don't care if you sing Nelly, it's hot in here, don't matter. Sing something so that you know you're washing long enough. And I'm actually going to go back to the picture so you can see something. When you're washing your hands, and I see this a lot in the restroom at Prism, remember, when you're done washing your hands, you need to hold your hands up. Because if you put your hands down, what do you think's going to happen? Any bacteria that's up here is going to go back down to your freshly clean hands. You ever seen, who watches Grey's Anatomy? I know somebody watched that show. Everybody I talk to is like they love it. I don't like it, but on Grey's Anatomy, when you see them wash their hands, they go like this, don't they? Hands up, hands up, hands up, so they don't contaminate their hands, okay? So turn on the water, wet your hands, get the soap. When you're washing your hands, row, row, row your boat, hot in here, whatever, interlace your fingers, get your palms with your nails, okay? Wash them good. And then when you're done, you rinse them very well, holding them downward under the water. You get a paper towel, start drying your hands, get another paper towel, completely dry your hands, holding them up, and then get another paper towel to turn the water off. Make sure you know that, okay? So that's hand washing. And then when it comes to using the hand sanitizer gel, if you're using it, and in facilities, yes, use it. I'm just saying don't overuse it like when you're at home or you're at the mall or whatever, once we get back to a normal life. You put the hand sanitizer in the palm of one hand, okay? And you rub your hands together just the same way as if you were washing them, right? In between the fingers, the palms, the whole 9 yards, about 20 seconds until it's dry. Okay, so that's the proper use of hand sanitizer. Okay, next, in order to stay away from pathogens, and I'm going to change this from organisms to pathogens, things that will make you sick, we have something called asepsis, which is either medical or surgical. Medical asepsis is the clean technique. Surgical asepsis is sterile. So when we're talking about certain procedures like tracheostomy suctioning, sterile. Foley catheter insertion, sterile, right? Those are sterile procedures. We're talking about wound care. It's clean, not sterile. We're talking about the care of an ostomy, clean, right? So all the stuff that you learned with Miss Sandy in foundations, it's all going to come back to haunt you guys in terms 4 and 5, especially in 5, because when we start prepping for the boards, you're going to hear me go back to fundamentals again and talk about Foley's and talk about trachs and talk about oxygen and all the other things, okay? So make sure you understand medical asepsis is just clean technique. Surgical asepsis is sterile and having that 1-inch border around your sterile field and don't lean over it and all those things that you learned, okay? Okay, so that's that. And then, what's this? No, don't need that. We talked about standard precautions, which are also called universal precautions. I'm going to put that here, also known as universal. And that just means that you are assuming everybody has something. And whatever they have, you don't want it, right? And then transmission-based precautions are the ones that we talked about that are specific to whatever the disease is that the patient has, okay? When we talk about precautions, here are the precautions for VRE. They have to have a private room. They have to wear gloves because it's contact. It's in the urine, right? It's contact. And the only time you need a gown is if for some reason you think there's going to be a splattering or splashing of the urine, you know, which I don't know, but you only need gloves because it's in the urine. So, you know, don't touch their urine with your bare hands. Okay. I'm not going to get into all of this. I want to talk about coughing and deep breathing though, real quick. When you're doing your care plans and you're scratching your head about certain things, remember this. If you have a patient that is either immobile because they're post-op or they're, you know, older and they're sedentary, they don't get around much, or somebody like me who smokes these, you know, there aren't vitamins in here. Contrary to what I thought for the past 40 years, no vitamin A in my cigarettes. Anyway, what you want to teach is you want to teach coughing and deep breathing. Why? Because people don't typically take a good deep breath in and out. So the technique is smell the roses and blow out the candles. Okay? Remember that line. Smell the roses and blow out the candles. What does that mean? It means that you teach them to take a very deep breath in through their nose. I'm going to show you. Deep. And then you're going to have them exhale forcefully through pursed lips like they're blowing out birthday candles. They should cough. Okay? If they're doing it right. If they don't cough, they are not doing it right. Because what you're doing is you're filling up your lungs to the maximum capacity, and then you're actually exhaling to get all that CO2 out at maximum capacity. That helps keep your lungs clear. It prevents any secretions from sitting and becoming infected. It can prevent pneumonia and different respiratory tract infections. I do it all the time. That's how come I could still smoke and run. Okay? So make sure you remember, you smell the roses, blow out the candles. Okay? All right, moving on. Don't worry about, we're not going to talk about that. And I'm actually going to get rid of this. Oral hygiene, I'll touch on that real quick, is very important. When people don't realize the connection between what's going on in your mouth and your gums and the rest of your body, but I'll just give you an example. When you go to the dentist to get your teeth cleaned, If you have any type of cardiac pre-existing condition, like a heart murmur or something like that, they're going to pre-treat you before you get your teeth cleaned with an antibiotic prophylactically. And that is appropriate because when they start scraping your teeth, which I love, I miss the dentist. They closed with this COVID and I'm overdue. Anyway, when they're scraping the plaque, that plaque can dislodge and get through your bloodstream and go right to your heart and give you either a pericarditis or an endocarditis. If you have a murmur, which is a problem with a valve, we'll get to cardiac later. But anyway, the point is oral hygiene, super, super important for your health in general. So remember that. All right, next. Let's see. All right, so for urinary tract infections, let's do this. Risk factors are urinary catheters, and then I'm going to say poor hygiene. So let's highlight this. The most common urinary tract infection in a nursing home is E. coli, Escherichia coli in older ladies. Why? Because older ladies, when they wipe after they go number 2, they move their bowels and they wipe, they oftentimes won't do it properly, or because of arthritis or pain or limited mobility, instead of wiping from front to back, they wipe from back to front. E. coli lives in your gut, okay? It lives in your intestinal tract, but it's kept under control, doesn't make you sick. But if you wipe the wrong way, you're wiping the stool near the urethra, and those microbes, those pathogens, the E. coli is like, oh, cool, we got a new place to party. Let's check it out up here. And they go right up the urethra, into the bladder, boom, UTI, okay? And when we do cultures on these patients, we have found statistically that it's greater than 89%. That's the most current number. You don't need to know that. I'm just giving it to you. I'll never ask you about statistics, honeys, because statistics change every minute. Okay? But just so you know, it is the most common type of urinary tract infection in older women in facilities, especially E. coli, because they don't wipe right. And then, of course, if you have a Foley catheter, guess what? You're at risk for infection just because you have a catheter in. It is a route directly from the outside into the bladder. A couple things I want to tell you about Foley's. If somebody has a urinary catheter, when it is emptied, when you empty the drainage bag, and I would bet $1 million right now that none of you have ever seen it done right, okay? When you empty that Foley, you are supposed to wash your hands, put on gloves, get a container, like either a calibrated container, and when you open up the clamp at the bottom of the urinary drainage bag, you release the clamp and then you let the urine drain from the bag into the container. You're supposed to wipe that drain with an alcohol prep before you close it back up. And I bet you $1 million, has anybody ever seen that done? Here's the other thing. If we need a urine specimen from somebody and they have a Foley, you never get a urine specimen from the drainage bag. Never. You take hemostats and you clamp the tubing, and then you get a needle and syringe and you go to the port up by where the Foley is coming out of the patient, and you drain clean urine out directly from the bladder into the syringe and put it into a urine cup. Okay. If I had a nickel every time I saw somebody just hold a urine cup underneath a drainage bag and pour the urine in, it's contaminated when it sits in the bag. You're not going to get an accurate urine analysis. Okay. So that, okay, that's enough with Foley's. No, don't worry about this right now. Talked about MRSA, Staph aureus, methicillin resistant. The treatment is Vanco. Okay, talked about that. It's very difficult to treat. We talked about VRE already. Combination antibiotic therapy and that. I'm not going to get into that right now. I'm going to get into this real quickly, and then we are, believe it or not, we're almost done with infections, as if this isn't enough. Antibiotic-associated diarrhea, which is really pseudomembranous colitis. Let's go right here. Let's do this. Okay. Antibiotic. Related. Okay. So anybody that's ever been on an antibiotic knows that, especially with the broad spectrum antibiotics like amoxicillin and penicillin and those kinds of guys, they kill the bad stuff that's making you sick. Yes, they kill those bacteria, but they kill your good bacteria too. So in other words, for women, you is baking bread down in your lady parts when you on an antibiotic too long, right? In other words, a superinfection can occur from antibiotic use. So you can get what we call a yeast infection, which is actually candida